Welcome to Kidney Corner, a series of informational podcasts designed to review the diagnosis, risk factors, prevention strategies, and management of acute kidney injury, or AKI. I'm Dr. Vanessa Moll. I'm an intensivist and anesthesiologist, and I have a special guest today, my favorite critical care pharmacist.
Hi, I'm Sarai Sword. I'm your critical care pharmacist. And during this series, we're going to follow the hospital course of our patient, Mr. Miles, while highlighting his progression into and recovery from AKI.
Excellent. We have prepared a patient vignette for you that I will read to everybody. Here we go. Mr. Miles is a 54-year-old African American with a history of type 2 diabetes, hypertension, and depression. He presents to the emergency department with complaints of fevers, chills, and abdominal pain. On presentation, he is febrile with a temperature of 39 degrees Celsius. He is hypotensive with a blood pressure of 70 to 50 millimeters of mercury, which correlates to mean arterial pressure of 57. He is tachycardic with a heart rate of 110 beats per minute and tachypnic with a respiratory rate of 22 breaths per minute. The physical exam is unremarkable except for a distended abdomen with focal tenderness. Per the sepsis protocol, the patient is initiated on Zosyn, piperacillin, tazobactam 4.5 grams IV every 8 hours and vancomycin 1 gram IV every 12 hours. He also gets a bolus of fluid and he receives a Foley catheter. Blood cultures and a comprehensive metabolic panel and complete blood count are also pending, and of course were drawn before he received the antibiotics. Despite the bolus, his urine output remains low, below 0.5 mils per kg per hour. His MAP plateaued at 63 millimeters of mercury, and his lactate remains high at 6 millimoles per liter. He receives another liter of normal saline that is administered, and norepinephrine is initiated. The comprehensive metabolic panel and complete blood count are within normal limits, except for chloride of 112 millimole per liter, serum creatinine of 1.72 milligrams per deciliter, and the white blood count of 19,000.
Vanessa, I think this is a good time to define AKI. However, I would like to first introduce the Kidney Disease Improving Global Outcomes Group, or KDIGO. Now, KDIGO, or KDIGO, depending on how some people like to say it, is a global organization whose mission is to develop and implement evidence-based clinical practice guidelines focused on kidney disease.
7 hours after presenting to the ED, Mr. Miles is transferred to the ICU for continued management of septic shock. Overnight, vasopressin was added to the norepinephrine, and the patient now has a sustained mean arterial blood pressure of 68 millimeters of mercury. Despite this, though, his urine output remains low, less than 0.5 mils per kg per hour this morning. The comprehensive metabolic panel and complete blood count are within normal limits, except for chloride of 114 millimole per liter. A serum creatinine now higher even at 2.25 milligrams per deciliter, and a white blood cell count of 19,000. His temperature is elevated. He's febrile at 39.5 degrees Celsius. Upon reviewing the patient's medical records from a previous admission about 3 months ago, his baseline creatinine was, when I reviewed the patient's medical records from a previous admission 3 months ago, I noticed that his baseline serum creatinine is actually normal at 0.9 milligrams per deciliter. That being said, we now have enough information to diagnose Mr. Miles with AKI.
Well, utilizing the KDIGO criteria, we can stage the severity of AKI from about 1 to 3 based on the degree of increase in serum creatinine as well as we can also look at the duration of insufficient urine output.
So, in the case of Mr. Miles, his serum creatinine is increased at 2.5 times from his baseline of zero point 0.9 milligrams per deciliter. Not to mention his urine output has been less than zero point 0.5 mils per mg per hour since he presented to the ED almost 18 hours ago. So that correlates to KDIGO stage 2.
I know we typically stage chronic kidney disease, but what's the significance of staging acute kidney injury? Is it really necessary?
Good question, Sarasa. The prevalence of AKI in hospitalized patients ranges from 10 to 50%, and then in the ICU, as high as 60%. Patients who develop severe AKI, or those with a prolonged course of AKI, or those unable to achieve renal recovery have an increased risk of mortality. And even a single episode of AKI leads to increased morbidity and prolonged length of stay in the hospital.
So it sounds like early detection, proper management, and prevention of AKI, when possible, is imperative. Well, when we talk about Mr. Miles, what we learned is that during rounds, the bedside nurse reports that the patient is complaining of increasing abdominal girth and worsening abdominal pain. The team becomes suspicious of an intra-abdominal process and orders a CT abdomen with contrast.
Wait. What about the KDIGO stage-based management strategy for AKI? You know, the avoidance of nephrotoxic agents and radiocontrast. Aren't there some specific drugs we should worry about?
Absolutely. Drug-induced nephrotoxicity has been reported to occur in up to 26% of hospitalized adults. The list of nephrotoxic agents is a bit exhaustive, so let me tell you the main classes. That includes many of our antimicrobial agents, except for macrolides, clindamycin, and tetracyclines, chemotherapy agents, immunosuppressants, as well as some of our commonly used medications such as NSAIDs, ACE inhibitors, or our angiotensin receptor blockers, also known as ARBs, and even some of our newer agents, such as our SGLT2 inhibitors. It's important to understand that it's not just the drug itself that can be nephrotoxic, but it's how the drug is used, the duration of therapy, as well as any use of concomitant nephrotoxic agents. All of these things combined can increase renal exposure and subsequent risk. Now, as empiric coverage for septic shock, our patient, Mr. Miles, was initiated on piperacillin tazobactam and vancomycin therapy. This is particularly concerning because individually, each antibiotic has potential for inducing nephrotoxicity. However, there are multiple reports that the risk of nephrotoxicity increases exponentially when pip/tazo and vancomycin are used in combination.
So let's wait to find out the results of the CT scan. But is there something right now we can do, Sarasa, to minimize the risk, or should we even change the antibiotics at this point?
Well, if a prolonged course of therapy is planned, I suggest checking vancomycin trough levels. Also, since both vancomycin and the piperacillin tazobactam are renally cleared, renal dose adjustments will be necessary, but we'll save that for another discussion. There's also well-established association between contrast medium and the development of AKI, secondary to endothelial cell damage and cellular death. Now, when we look at contrast-induced AKI, this is defined as an acute increase in serum creatinine within about 48 hours of exposure to contrast medium. Now, KDIGO recommends that alternatives to contrast or radiocontrast procedures be considered. However, when we look at Mr. Miles, a CT scan of the abdomen really is necessary to rule out an intra-abdominal process. Therefore, the best prevention is to use a low dose, low osmolar or isoosmolar contrast medium. In addition, we should optimize the patient's volume status with intravenous isotonic crystalloids or sodium bicarbonate solutions as opposed to having any orally administered fluids. Ideally, we should hold any nephrotoxic agents at least 24 hours prior to administering any contrast and resume those agents once the renal function normalizes. Unfortunately for Mr. Miles, withholding antibiotics is not a feasible option.
Yeah, very, very true. There has been a lot of talk about using NAC and acetylcysteine to prevent further worsening of his renal function from the contrast in the past. What is the latest research on this?
Right now, there's insufficient clinical data to support the use of N-acetylcysteine, or NAC, to prevent AKI. To date, NAC has not been shown to decrease mortality, utilization of renal replacement therapy, nor has it been shown to improve glomerular filtration rate, or GFR.
Mr. Miles receives a bolus of 500 cc's of a balanced crystalloid, both 1 hour before and 1 hour after his CT scan with contrast of the abdomen. We have confirmed with the radiology department that a low dose of low osmolar contrast will be used for the procedure.
Vanessa, is there any particular reason for using a balanced crystalloid versus normal saline?
Great question. Yeah, there's the SALT ED, Smart Met, and Smart Surge trials, and they suggest that the use of normal saline is associated with an increase in major kidney related events. Normal saline has been associated with hyperchloremic metabolic acidosis and renal injury. Since our patient has hyperchloremia in addition to his worsening serum creatinine and is preparing for contrast exposure, a balanced crystalloid, which has less chloride per liter, seems like the best conservative approach. Shortly after Mr. Miles returns from the CT, the radiologist notifies us that the findings were suggestive of an intra-abdominal abscess. We immediately contact the interventional radiology interventionalist and schedule Mr. Miles for placement of a percutaneous drain tomorrow morning. So for tonight, Mr. Miles is tucked away. I just gave my sign out to the covering provider, and our shift is now over.
We hope you'll join us for more Kidney Corner as we continue our journey through the hospital course of Mr. Miles. For the KDIGO guidelines on acute kidney injury, go to www.kidney-international.org.
Excellent. Well, thank you so much, Saressa, for joining Kidney Corner. And we shall be back with our second episode following Mr. Miles. And I think now it's time to rehydrate ourselves. So everybody have a good day.